to treat every patient equally is unbelievably ridiculous considering the social determinants of health. It was at a point where physicians were like, I've had enough. I'm so overburdened, under-resourced. I don't want to do this anymore.
Dr. Maryam Zeineddin is a family doctor. She is dedicated to providing high-quality, comprehensive, and patient-centered family medical care. Dr. Zeineddin is the founder and chair of a preventative health platform called ZillaCare, bringing tools and insights on how to take ownership of one's mental and physical health.
Every physicians in the States understand is that we, as a physician organization, is the negotiating body for all physicians. And every 3 years, we negotiate a master agreement. I remember in 2019, before COVID hit, we sat and wrote this memorandum of what we want family practice to look like. Now you get paid per hour of your time, and then you also get paid for the complexity of your patient panel. And the biggest win for us was that we also get paid to do indirect work.
Welcome to the InterestingMD Podcast, the show about what doctors do when we aren't seeing patients and how this can help us find balance and prevent burnout. I'm your host, Rob Beck. Welcome back to another episode of the InterestingMD Podcast. I'm your host, Rob Beck. So this week I have a really wonderful guest who is going to be able to explain the ins and outs of primary care in British Columbia. We're going to have a lot of questions and a lot of information and discussion about what primary care doctors do, who can be a primary care doctor. So there's a lot of interest for this because of a lot of the American physicians who are looking to move up here. And so hopefully we can give them a lot of wonderful information. So before we get started, I just want to thank everybody. Again, please continue on with the questions that you've been sending, the comments, everything. I'm trying to respond to everybody. There have been lots of people who have reached out to me by email and looking for more information. And so please keep it coming. And I really appreciate it. If you can, like, subscribe. That way it helps people, give me a rating if you can on the podcast. That would be very helpful, as long as it's a good one. But I'd just like to get started. So this week I have Dr. Maryam Zeineddin, who is a family medicine doctor you're in West Vancouver, is that right?
Correct, yes.
Correct, all right. So she is going to be here to tell us all about herself, but also about being a family doctor in British Columbia. So please, without any further ado, Dr. Zeineddin, Dr. Z, welcome to the podcast. Thank you so much for coming on.
Well, thank you, Dr. Beck. I'm very excited to be here. And I'm just very honored that you chose me as the family doctor.
No, thanks for replying.
Well, thank you. I thought maybe you'd reached out to me because I just was the president of BC Family Doctors here in British Columbia. So I thought maybe it's all the title, but maybe it has nothing to do with the title.
No, it is the title. I figured that. So Dr. Paul Hertz, that I believe that who was on the podcast a few months ago, I said, okay, who can give me all the information that you just gave me? And Paul said, okay, you need to reach out to her. So did a little bit of research and thought, I absolutely need to reach out to her. So thank you again. I really appreciate it. So you're in West Vancouver, but do you mind just telling us a little bit about you, about where you are from, where you went to school, did your training, what kind of practice you have, that kind of stuff?
Yeah, so I am a Iranian-Canadian physician, born in Iran, raised there till I was 7, and moved due to the Iran-Iraq war with my entire family. We moved to a couple of countries before we landed in Sweden. I speak Swedish very randomly, and I speak Farsi, but it was amazing living in Sweden because, they have a very wholesome healthcare system. And I wasn't sure if I wasn't going to go into medicine really right after high school, because you had to pick in Sweden, you have to pick what you want to do right after high school and you have to rank it and then you get what you want. So I ranked everything. I ranked medicine and everything. And I actually got international law, and I had to say no to international law because I wasn't fully convinced I was going to be an international lawyer, even though it could be humanitarian work too. And I had also applied for UBC, so University of British Columbia here in our province. And I got in and I was in sciences and did physiology as my undergrad. And I loved it. And then went into medicine. And to get into medicine here is not as easy. Obviously, it's still not easy. We have expanded our medical schools by quite a bit, but back in the day, I'm not giving you away my age, but I have practiced as a family doctor for 20 years to be exact. And I am turning 50 next year.
Congratulations. Yeah, you and I are basically the same age. So,
okay.
Yeah.
Damn
so,
it.
Yeah, I know. It's okay. we both remember, you remember it differently, but you both remember that conflict, the Iran-Iraq war. So a lot of people are like, oh, I don't remember that one, but
yeah, quite a war at the time. And and my father worked for the Red Crescent at the time, was the head of the Red Crescent. So all the humanitarian stuff and the 5,000 staff was all going through him. So to be worthy in my family, I had to be socially responsible. So hence,
I was going to say, hence the international law.
Yeah, exactly. Hence the international law, hence going into medicine, hence becoming a family physician. Although I don't think my father was very thrilled that I went into family medicine. He really wanted me to be an internist.
It's overrated.
Or cardiologist.
Yeah, it's overrated.
Like
it's overrated.
And I was like, no, but I kind of want to see kids and I kind of want to do this. And I really wanted to do obstetrics and I didn't want to be a gynecologist. So here, the beauty of being a family physician is that you could do it all, really. Yeah. And I did. I really was one of those dinosaur family docs who finished. We have a 2-year residency after medical school. So you go through your undergrad. It's very hard not to finish undergrad and then apply for medical school because, here the Canadian system is a public system. So there's equity in our system, slight equity. And so you apply for medical school and, one in, 10 or 20 people get in. So it's a bit of a lottery in some way. We all have to write our MCATs. You guys have to write MCATs too, right? Yeah. So we have to write our MCATs. We do our interviews. And back then you got interviews with 3 people. Maybe the dean, and now it's standardized interviews like OSCE type that you go through for medical school, and then hopefully you get in your first try, which I did. Although I took a year off actually in between medical school and residency. Yes, I was a ski bum, so I taught skiing in Whistler against my family's will. And
You're like, Dad, this is the one time I'm going to go off. I'm going to prevent disease. I'm going to heal people.
Yes,
I'm going to bring life into this world. But I need to go ski in Whistler for a year.
Actually, it wasn't a year. So I actually I did a humanitarian. I went with the Canadian International Medical, it's called Canadian International Development Agency back then. As a volunteer to Honduras, of all places. And I worked at one of the biggest hospitals in Tegucigalpa and worked there for about 6 months, got stuck in a hurricane, then came back short of the 6 months and then became a ski bum.
Well, good for you.
Yes.
Did you at least learn to surf when you were in Honduras, or?
I got my scuba. I got my diving certificate. Scuba. Yes, So if you really want to be a scuba, like a really cool hippie, which I was back in the day, you go to the Bay Islands and you go to a place called Utila, and Utila does not have any streets, does not have any, and I had only one pair of flip-flops and I lost them. And there's nowhere to buy shoes there. I want to give you. I'm sure there is now.
Right, probably now. There's an island in Belize like that too.
Belize is similar. Belize got the similar. Where did you go? Key Calker?
Key Calker. Yep, that was it. Yep.
I've been there too.
Okay, yeah, that's where we actually went on our honeymoon there and ended up going there and just thought that was. We went to several different places, but then we ended up there and that was just absolutely phenomenal.
And you kite surfed there?
No, we didn't do any of that. We did do swimming with the nurse sharks and the big rays and stuff like that. So
that's what you have to do.
Yeah. So my wife wasn't huge on scuba diving at the time. And so.
Yes, I actually had a pediatrics colleague who I'm not going to mention her name, but she's a pediatrician. And she stood up at a bar one night and told all the scuba divers, the very, very amazing scuba divers, that this is not natural, people. There is still an oxygen tank. And I was like, oh God, you're going to kick us out of this bar.
Right. Yeah. Now, at some point, I'm hoping to have on a free diver talking about free diving, and they will be natural. They don't get to stay down quite as long, but
fair enough.
Yeah. So we may talk about free diving as well.
Okay. So, well, there you go. Yeah. So, it's all about being that, having that sense of freedom before you go into medical school. And then when you go into medical school, medical school anyways in Canada was really fun for me because I was already a physiologist. So the first 2 years are pretty easy, especially if you come from a science background and you already know the physiology that they're going to teach you. And then the third year is more clinical work, and fourth year, you're just perusing to figure out what you want to do. So I did some very cool things. I went to Brazil to do obstetrics there. I went to Iran, to Tehran, and I worked in an internal medicine ward. So it was like so fun.
Wow. So you got to go and have a lot of fun.
Yes,
definitely.
Yes, I did. And then I went into residency, and in residency program for family practice here, we have multiple residency sites. In fact, I believe our residency site for UBC is the largest, I want to say, in the entire world, because the head of the residency program happens to be now a good friend of mine. And he always uses that now in his speeches. That's why it's he's like, it is the biggest in the world.
So, I did not know that. Yeah,
it's quite a lot. The site, there's multiple sites. I can't give you the exact number, but I think it's at least 19 sites. Yeah. So I did my 2 years of residency at St. Paul's, at the St. Paul program. And St. Paul's is a very, very sort of inner city hospital in the middle of downtown Vancouver, where we get a lot of addiction medicine, a lot of trauma. It's just kind of the hub of everything. So it's a great place to do your residency, and it's a hard one to get into. So, and I did that for 2 years, and then I ended up marrying this amazing guy who I'm still married to, but he was very annoying. He was a dentist, and also went to UBC, did physiology, and then did dental school. And we made a pact because he wanted to go to Texas, actually. He wanted to go to Texas to do the oral surgery program there, so he could be an oral surgeon. And we kind of compromised. I said, okay, well, what if I do family? I don't rank any of the other specialties. I do family, and you do general dentistry, and let's see how we do. And if we hate it, then we could go back and do some more training. And so he did, and he loved it. And he still does quite a bit of oral surgery still now, because he did extra training. But he started a practice in West Vancouver. And I was like, well, what am I supposed to do? Like, I'm not going to just be doing locums. And you can, most normal human beings that finish their residency, they end up becoming locums, or, just to get a sense of what other practices are like. But no, not me. I took over some poor lady's practice like the day I graduated from residency.
Wow. So you walked out straight into a job and straight into the deep end. And so here in Canada, most of the family medicine practices are individual standalone practices. Is that right? Solo practices?
So yes and no. We have now, there are multiple ways to join practices. So back in the day when I joined a practice, I didn't actually join a practice. I took over a solo individual's practice, and I didn't even have to buy it because it's not worth anything.
Right.
So they just
That's also different from kind of like a dentistry practice, or
very
even a lot of the practices in the United States. Like you would just kind of buy a practice, you would buy a chart, or that you would buy into a practice. Most doctors in the United States States now are employed physicians by a hospital or like a larger, huge multi-specialty group. So, but here for family doctors who are wanting to come up here and practice primary care, you would technically be able to just walk in, open up a shop or take over somebody's practice without really having to buy into it. And you're not really building up your practice. You're just generating income, and you're not building up your patient panel to then sell it off later on.
Yeah, because there's so much demand. We have about 5 million people that live in British Columbia. About 1 million of them didn't have a family doctor until just 2 years ago. 2 years ago, we changed one of the payment models for family physicians, and I was part of that negotiation. And when we did that, we got this influx of physicians, having been working in hospitals as hospitalists or doing locums, or they were just new physicians, really afraid of actually coming in and committing to a cohort of patients with fairly low income to now join because, we did get a raise, and the way the payment model is now set up is the majority of family physicians now are attached to this new payment model because it's so well thought through. Even with the payment model, coming in and opening your solo practice, you can, but it's quite lonely. So the best sort of way to kind of do it is if you can join a group practice. Now, a lot of the group practices are being sold by corporate entities. I still haven't sold. I'm a part of business owner with my medical school classmates. And we have a clinic, a small business, basically, a clinic that is giving service to over 10,000 patients, probably 15,000 patients now. And there's 8 of us that are practicing sort of part-time to full-time with about 6 to 8 staff. So it's become bigger than when I took over the one lady's practice.
It's grown. Yeah.
It's grown. Yes.
Your practice has grown. Yeah.
Yeah.
So do you mind explaining that new compensation model and just kind of giving us the details, because people have really been curious as to what it is? Because in the US, it is a completely different beast and a different model.
Yeah. So I'll tell you how we were paid before. And a lot of people are still attached to the fee-for-service model. Fee-for-service means that, when the patient comes in and sees you for whatever the issue is, you just get paid for that visit. And it was quite nominal. Actually, it was like, I don't know, somewhere between $30 to $40 per visit. And imagine that's why the physicians then now had to see at least 6 patients an hour just to pay their overheads. 6 patients means you would give and allocate the max amount of 10 minutes for your patient. And you would also have to do all your notes at the same time, because you're not going to get paid for all the administrative burden you have afterwards. So it was a grind for so many of us that wanted to do good medicine. And for the ones that actually wanted to be like, now tell me a little bit more than what I'm band-aiding you for.
Yeah. You got paid for one problem. Is that right? Is that what the last system was for? It was, you get one problem. And that's it.
So one fee for service, like basically one fee. And yes, there was an age allocated, so you got a little bit more for the older population. And then they brought in some complexity. So, I think it was an old white man who came up with the complexity fee, because all the illnesses were not very equitable for women at all. In fact, it was if you have diabetes, chronic kidney disease, COPD, neurodegenerative disease, and cardiovascular disease, and maybe asthma. Yeah. That's called complex. Oh, and liver disease. That's nothing about cancer, nothing about mental health, nothing about women's health, nothing. That was complexity. And you got $300 a year for the patients that are considered complex for that. But that model just wasn't sustainable. And in fact, every physicians in the States understand is that we, as a physician organization, so Doctors of BC, for instance, is the negotiating body for all physicians. And every 3 years, we negotiate a master agreement with them. So with inflation, they kind of give us a bump. It obviously, for the family doctors who were paid the lowest, getting the same bump as everybody else created even more of an inequity for them. And it was at a point, we were at a crossroad where physicians were like, I've had enough. I don't want to do this anymore. I'm so overburdened, under-resourced. And so I remember in 2019, before COVID hit, we sat and wrote this memorandum, of what we want family practice to look like. And this was done by BC family doctors. So BC, the family doctors have their own association as well, called the Political Association and Economic Association is called BC Family Doctors. There's multiple other organizations as well that we work with, but they're the ones that allocate the funds and do all the sort of payment models. We were still operating with this fee-for-service model in 2019. The government had come and also given us some option to be salary-based. For some sort of complex population, they were starting to give them salary-based and make them into employees for the whatever health authority they're working for. And then they brought in contracts. They brought in contracts for new to practice. They said, well, if you take, 1,000 or if 800 patients, we'll give you X. And actually the contract still existed till very recently. We will give you X thousands of dollars per year to work for us. So you're not billing per patient, you're just getting paid a salary.
Right.
And
for your panel.
Yeah. But most people were still on fee for service, 80% were more than 80% were on fee for service and very unhappy. The older population were less unhappy. The younger population and Gen X, I'm a Gen X. So Gen X and younger were miserable on that payment model because we didn't want to see 6 patients an hour. It's brutal. So long story short, pandemic hit, situation got even worse. And the good thing is that we went to virtual care overnight. So we got billing for virtual care, but we were able to get the premier of British Columbia to agree to meet with us and come up with a completely new payment model. And so we negotiated that new payment model, which now it's called the LFP, which is called the Longitudinal Family Practice model. Everybody knows that it's a new payment model. Now you get paid per hour of your time. You get paid for your encounter, but much less than the $30 to $40. You get about $25. And then you also get paid for the complexity of your patient panel. So overall, and the biggest win for us was that we also get paid to do indirect work.
So going through your labs, writing consults, doing your notes, all of that.
So that you bill an indirect code. It's about $130. It's not as much as when you see your patients, but it's something.
Yeah.
It's better than nothing.
So for the US doctors, when I would do that they would give you, that the insurance companies would give you a set price. And so, okay, here's your level of complexity. And it was a ridiculous set. I think that it's changed since I moved about you kind of have low complexity and high complexity, but there used to be 5 levels and different requirements for all of that. But anything that we did, even the most high complex patients, anything that we did was then the follow-up. So the labs, the phone calls, the prescription refills, the referrals that you had to send off, or any of that stuff, they just said was included and that they couldn't pay you for any of that. And that really is one of the biggest things that just shocked me about being here in Canada is that we have codes for all of that, except for family medicine when we first moved here. But we actually have, so for the United States, we just don't get paid for that. And they just say that that's included. And so here now it was amazing to me that we actually get paid to call in prescriptions and do all of those things, even from a specialist standpoint, But it's really nice to hear that you guys actually have that as well to pay for your administrative time and recognize that time away from your family and time away from your hobbies and whatever else you want to do is actually valuable. And so that's pretty amazing.
Yeah, that was a huge win for us to be able to get that sort of time fee for indirect work. One of the sort of biggest win for us, because I'm a big sort of women's health advocate and I'm a big equity advocate, was that, to treat every patient equally is just unbelievably ridiculous considering the social determinants of health. Being female is a social determinant of health. And in fact, especially as a female family doctor, 80% of my patients are female. So we could tell that female physicians were actually being penalized financially by caring female patients who had complex issues that were never even looked at. I mean, if you actually look at the ICD codes that you had to put, you have to put ICD codes for your billing, like you put your bill and then you put the code. They don't even have like premenopause or perimenopause. It's all postmenopause. Everything was anxiety. Like literally that's the code we'd be using. And in fact, even for vaginal exam, speculum exams, we would not get paid the tray fee of the speculum, but only if we did a PAP. And you only do a PAP every 3 years. And it's like, oh, so even the way the physicians were taking care of patients, especially female patients, they were just not even examining them. So now I am very happy to say that when you examine a female genitalia, you don't get paid $25, you get paid $60. And we achieved that by saying the word vagina over 37 times in 1 hour.
All the old white men are like, oh my God, stop,
like,
fine, we'll just pay you. We'll just pay you.
We'll just pay you. I'll give it to you. And then we actually got the $60 and we're like, oh, okay, we'll take it.
Yeah, you're like, okay, so if we say it one more time, 38th, we're going to have it withdrawn, so we're fine. We'll just stop while we're ahead.
But it's about time. I mean, I think it's very, it's very fair. And in all fairness, it has improved the female physician income as well as helping our female patients really feel heard and seen. And now, we had physicians stop inserting IUDs because it wasn't worth anything. And now all of a sudden to put in an IUD is $110. So guess what? All physicians are putting in IUDs.
Yeah. You pay what you find is important and, you pay for what is important. And that's
so
really
in a way,
amazing.
it's been a huge systems change. But it's new. The payment model is new and it still needs refinement. The complexity codes are still not calculated the way we would like it to be calculated. Mental health is not picked up. Cancer care is not being picked up. But at least you're getting paid for your time. It's just that we don't want to incentivize poor care just because these things are being picked up. So we have to go back to the negotiating table and really push for some of these changes. The problem has been is that your country, the United States of America, has put some massive tariffs on us. And so the government's like, so they don't want to.
Kind of all the negotiations are off right now that everybody's kind of putting things on hold.
No, it's not off. We're still in negotiations for the master agreement, the big master agreement. It's still happening. It's just that it's just not going to be the same master agreement when I was there last.
Belts are being tightened a little bit thanks to the tariffs, unfortunately.
Yeah, but I'm very glad to see this government really open the doors for our fellow U.S. physicians to be able to come and move if they wanted to, because we are in need of physicians. Let's be honest, it's a win-win. And it's also, I have to say, the College of Physicians and Surgeons are the ones that have kind of taken ownership of accrediting you, immediately versus going through all these hoops that other foreign trained physicians have to go through. It's been also very unfair for them because they're like, "Ugh, so these US doctors."
Yeah. Yeah.
So in a way, I have to almost apologize a lot of times for our other non-US foreign physicians because they have to go through so many hoops just to get to the training program because they won't even get their license as the specialty that they're in. The other thing is with you guys, I wanted to talk to you about that. Actually, I wanted to ask you the question is
Please.
that, primary care is quite a large umbrella. Whereas for us, to be a primary care provider, you have to be a family physician of 2 years past medical school training to then get your CCFP, which is the college accredited family physician. But I hear that the US docs also have primary care and pediatrics. There's all sorts of sort of specialties that can do primary care.
Yes. So to kind of get in without a referral, it would be pediatricians, family medicine doctors, internist, and OBGYNs, actually. So a lot of younger women would have their primary care done through their OBGYN. And that was obviously the OBGYNs would be, mostly just kind of sexual health. But when you would get diagnosed with hypertension or diabetes or whatever else, they would put you somewhere else. They'd say, okay, you need to go get somebody who wants to do that. But yes, in the US, you can self-refer to family medicine, pediatrics, and also internal medicine. And so internal medicine is a bit different here than in the US, but I think there are 70,000 general internists in the United States, whereas there are 100,000 doctors in Canada total for all specialties across the entire country. And so that's just like, there is almost the same amount of variability of what internists do in the United States versus here. I mean, there is just a huge wide spectrum. And I've actually had a lot of internists. So I did do primary care for 9.5 years, almost 10 years when I was in the US. But we did also all of our own hospital admissions. We took care of all of our own patients. It was kind of a traditional practice that we did. But the vast majority, 95%, I think, of all the hospitalists in the US are internal medicine. So less and less so family medicine now. And so there's this very, very wide spectrum. And there are doctors that take care of patients in the ICU, and there are doctors that don't, and doctors that do procedures. And then there are doctors that have completely outpatient-based, clinic-based practices that don't go into the hospital. And I have had some doctors reach out to me that, hey, I'm an internist. I've been an outpatient internist. Would I be able to just come up and do family medicine? Like, I just want to come up. I want to do hypertension. I want to do diabetes. I want to do wellness visits, and I want to do pap smears. Can US trained internists, I mean, they would come up and they would be a specialist. Like, that's their designation that they would get, because if you're a board certified internist, you would be designated as a specialist. So would those doctors, do you know if those doctors would be eligible for this practice or this payment model? Or would they just need to open up and bill as a general internist?
Yeah, so that's a very good question. And that's kind of what we're having a bit of a hard time with, because the way a internist is trained is still very different than a primary care provider. We really deal with cradle to grave. So you'd have to be able to do a newborn exam, and you'd have to be able to take care of kids from the age of 0 to up to like, it's not just adult medicine. But there are some physicians who only do a very sort of very focused care. So, I have a colleague, for instance, who only does women's health. So her license is only good for all the women's health issues, all the birth control, the IUDs, the perimenopause and menopause. Like, she cannot see any of my patients who potentially have bronchitis or pneumonia or do,
no BPH.
No.
Okay.
So there are ways to potentially get some of those designations. It's just also, it just becomes a bit trickier because now we want to understand which billings can they now use. Are they using family medicine billings or can a general internist go and actually use internal medicine billing codes? And so this is kind of where government never thinks through and they never really consult us. And so
everybody come in. How are we going to get paid? I don't know.
And we want to be as inclusive as possible. Don't get me wrong. Like we want to make it work for everyone. But some of the specialists here are like, oh, but like, how are they coming and taking our billings? And so there is a little bit of politics involved for sure. Maybe not so much for family physicians. We're just a nice bunch of people.
I can say that is true. That is very true.
Yeah. We don't have as much ego attached to ourselves. But having said that, the family physicians that are in Canada, we are starting to call ourselves specialists in primary care. And we don't call ourselves GP as a general practitioner, even though it's quite common to use that word. But we're either calling ourselves family physicians, family doctor, or specialists in primary care. And it is a very political move for us to be able to really make the public understand that we are not nurse practitioners, even though nurse practitioners do also primary care. Mm-hmm. It's just that they're trained very differently than us. And originally, the creation of nurse practitioners were that they were supposed to be with us, not functioning as solo practitioners. And that, again, is a political move, which unfortunately some can say doesn't serve the healthcare system. Just because nurse practitioners are fantastic in what they do and they hold space for the patient. They spend a lot of time with the patient, but are they true diagnosticians? Probably not, because they don't get trained the same way as we do.
Right. Yeah.
So then they utilize a lot of our resources. But having said that, I love all allied healthcare providers, and I really wish we could, be functioning all together in a team-based setting. It's just that our government also wants the most responsible physician the most responsible person for the patient to always be the physician. So it's a little unfair, I gotta be honest.
Yeah. So all of this is very confusing. Now, I will say that if you're an internist and you want to come up here and you just want to do office-based medicine, I don't know what you will bill as a specialist. You will bill as the specialist codes, which are typically higher than the family medicine codes. But I don't know how much restriction there is. I mean, I think that you can kind of find something. I don't know if you'll get billed for the pap smears, and I'm sure that you would. I don't know why you wouldn't. I don't know if that's something that's restricted only to family medicine. Do you know if like a speculum exam or?
Well, the new payment model is restricted to only family physicians. So that's the other thing. Like, it hasn't been expanded to any other specialty. In fact, it's very restricted to longitudinal care. Yeah. So you'd have to carry a cohort of patients. And in fact, right now, the minimum I think is 250. I mean, none of us really have 250. We have like over 1,000 patients at least. Yeah. But that's a very good question.
Many, many doctors in the United States right now are like, wait, what? 1,000? Yeah. When I left, my patient panel was about 2,200 and my wife's was 2,500. And that was kind of like a medium sized, one of my partners had 5,000 patients attached to his panel. And so
1,000 is nothing really.
Well, and it would be glorious. It's not nothing. It's just glorious, right?
It's doable. So they can, because the other thing with having such a large panel is that you also have to have access. So you have to be able to be accessible for more sort of urgent day-to-day visits. Like even for someone like myself who's got probably 1,200 patients, I go to the office, I do clinical work 2 to 3 days a week. Like I have to make sure I have same-day access. Mm-hmm. And sometimes that's very difficult for my own patients because They're like, oh, we can't book online. I'm like, call the office and I will squeeze you in. Like,
Yeah. Yeah.
but yeah.
Do you mind just kind of telling the family doctors what your practice is like? So you go in, you do clinical work 2 to 3 days a week. When you're doing that, you have administrative work other times, but how many weeks a year do you work?
I don't take that much time off. I probably would take 2 weeks during spring break because I have kids that have spring break, and maybe 2 weeks during the summer season, and then sort of weekends here and there. But I do know of physicians that take quite a bit of time off, especially if they have someone covering their practice and covering their overhead. They just don't make the income. That's the thing. So you're okay with not making the income, but you just don't want to lose income when you leave business. That's why a lot of people are not necessarily business owners, because business owners, they have an overhead, regardless if you're there or not. Like for us right now, we are in a group practice. The other physicians pay us a overhead from their billing. So they pay about 30% of their earnings to us, because that's what our overhead is. Locums get better. They get like 80% because we're in desperate need of locums. And then with that pot, usually like when our bookkeeper kind of talks to us, he goes, oh, so you guys are not for profit, right? And I'm like, yeah, technically. Because he's the same bookkeeper as my husband's bookkeeper.
Oh, okay.
Like, oh, your husband's not a not-for-profit. I'm like, no, he's for profit.
Yeah, nope,
but
he doesn't.
If I was a single mom, could I still make a living off working 2 days a week? No, you'd have to work full time. Like you'd have to work and see patients minimum 3 to 4 days a week to actually make a living, especially if you're living in Vancouver or Vancouver Island.
Yeah, the cost of living is quite expensive here.
It's quite expensive. Right. So, and also for someone like me, I do clinical work 2 to 3 days a week, and I'm a business owner. So my overhead's probably slightly even lower than everybody else's because I'm also the medical director. So I get paid as a medical director as part of our fees. And then I do leadership work, and leadership work pays hourly not the same as seeing patients. Right. Hence we don't have enough leaders in this world. But
yeah.
But, it does change systems. We do need people that are in the thick of it that have vested interest in making changes.
Yeah.
Most people that go into leadership are either, they're in academia or they're salaried physicians. When government says no, they're not going to be like, no, there has to be a different way because we're going to leave otherwise. So we had a momentum working for us, and it wasn't just us. It was our patients, grassroots organizations, the media. Like we had everybody working with us to make this payment model happen. And
yeah, there were signs in all the yards. Everybody deserves a family doctor, all of that stuff.
And actually it all started in Vancouver Island. So BC Health Matters was a Vancouver Island sort of patient-run organization.
Yeah.
Yeah.
So, I mean, what I'm hearing from you is that there are still lots of spots that are open that for family medicine. I think most of the family medicine doctors in the United States, I think it's a 3-year program for the most part. Right. And there are actually also combined med peds programs. That's a 4-year residency in the United States, but you do half medicine, half pediatrics, and not as many electives. And so those people so if you have a med peds, if you're board certified in both, you probably would be eligible for this longitudinal care maybe, or, because that's for med.
Those are the exact people we don't know what we would do with. Because they would, maybe the college would give them a designation as family docs and not pediatricians. I don't know what the college would designate them as. In fact, it would make sense if they were in primary care, because I have a feeling the pediatricians here in Canada would be like, oh, but my residency is 5 years and I have this and I have that. So why are they using my codes? That's where it gets complicated, where the government actually didn't think of anything, because we don't even have such a thing. Like we don't even have
dual certified.
Kids have, like, we don't even have those residency programs here.
So still a few things out there, but
we
that's
have
kind
to
of the
sort it
cradle
out,
to
and we
grave.
will. So, I would still not get discouraged to reach out, especially to the College of Physicians and Surgeons. For the family docs out there, just to get more information as well. In terms of just the politically and financially, what it would look like, you could always contact BC Family Doctors. They're excellent organization. And then there's the Doctors of BC, which is kind of the political and economic voice of all doctors. And they're the ones negotiating right now for the big master agreement. It is what it is. I will not be criticizing anybody.
Yeah. So do you have any final advice to U.S. trained physicians who are thinking about coming up here, aside from reaching out to the college and the Doctors of BC, Family Doctors of BC, or BC Family Doctors? Any advice or encouragement or?
Well, I would really sort of look at everything more holistically. So I would look at what does your family look like? What are you actually looking to achieve in your family life and in your personal life and in your own health and well-being? And how can you achieve that? If you're feeling the turmoil of what's happening in the US and you don't feel that sense of safety, Canada is a very good option for you. And in all fairness, our system is not perfect at all. In fact, whatever your system is over there, it's pretty similar here, if not sometimes in some elements is not necessarily any better. Our system is broken, but we are very cognizant around changing it. There's many of us out there that are for, work-life balance, even though it's very hard to achieve. And it's a beautiful, beautiful province. So this is the province every Canadian wants to be in. So let alone, Americans. I remember I used to do I did my residency interviews for my after medical school for the residency interviews, and I did them all over Canada. And they would be like, "Why are you interviewing here?" And I was like, "I don't know. What do you mean? I would like change. It's great to come to Nova Scotia." And they're like, "Uh-huh." Because they all knew. They're like, BC trained doctor really leave BC? Like, what are the chances? Although some of us do leave and then come back because they want you to go and never come back again. They don't want to train you and then you not stay in their province.
Right. Yeah.
So, yeah.
Well, thank you so much. I really appreciate you taking all the time and for doing all the hard work. Again, like you said, there are a lot of problems with the system here, except for a lot of those could be solved if we had more doctors and we had more people here to take care of these patients and to get them through into the system more efficiently and through the system. So I would encourage everybody to reach out.
Yeah.
Thank you so much for coming on. I really hope that we can talk again soon.
Yes, absolutely. Lovely meeting you.
All right. Thank you. Thank you for listening to another episode of the InterestingMD podcast. Please check out my content on YouTube at InterestingMD and follow me on TikTok, Blue Sky, Instagram, Threads, and Facebook at The InterestingMD and on X at InterestingMD. If you have comments or questions and want to get in touch with me or any of my guests, please DM me on socials or email me at rob@interestingmd.com. If you have any ideas for a show and you want to share your hobbies with me or don't know where to get started on your own project, you can email ideas@interestingmd.com. Please like and subscribe to the podcast and YouTube channel to get the latest content. Much appreciation to Falter Media for editing, producing, and posting all InterestingMD content. Check them out because if they can do this for me, imagine what they can do for you. See you next week.